So this is Kirsten Dell. She was a stud athlete at the University of Missouri.
Thank you.
She hosts several records if you want to get your Google on. There's like tied for seventh in all-time history in home runs. I think it was like 32 if I remember. But she's a pelvic health physical therapist or a physical therapist, and she also works with people in pelvic health.
Yep.
Right now, her caseload is about 50% pelvic health, but she's expanding her practice to work with men as well. So I don't think she's going to grow that because she's very passionate about helping people move well, like hips, knees, and all that jazz. But I wanted to bring her in for this because, number one, she's super smart, she's cool. This is something that not enough people know about, and pelvic health's important. So we've made space for this at the studio. I'm happy to have you. And if you have any questions in the future, I'll be holding this mic. I'll need to bring it to you. Hope you have a good time and learn some things.
Awesome. Great. Yeah, so I'm Kirsten Dell. Still weird to say that. I just got married a month ago, so. But I am a physical therapist. I went to the University of Missouri for undergrad. I played softball at Mizzou. I'm originally from Southern California, found my way to Columbia, and I just love it. So hopefully after 8 years, I consider myself a townie. And then I went to PT school at Mizzou. So it's a 3-year doctorate, clinical doctorate. Within the clinical doctorate, you have 40 weeks of clinical coursework. And so my first 2 clinicals were just kind of general, acute, ortho. And then my third one, I kind of showed up to an ortho clinical thinking I'm going to treat hips and knees and backs. And she goes, I do pelvic floor. And I was like, you do what? And so 2-3 weeks into that clinical, she was like, go for it, and so I started treating internally, and I just really developed a passion for pelvic floor. I think I was just telling you, I like to talk about things that are taboo and shouldn't be taboo. I like to kind of lessen that weird feeling for people. We say vagina and penis and organ all the time. We say those words in our clinic all the time, and they're just normal. And so it's something that I've really grown a passion for. And I do really have a passion for ortho and movement and just general kind of the study of movement. And so that's why I've kind of capped my caseload off at 50% pelvic, and then I still treat my fun back, hips, knees, shoulders, all of those things. But it all goes together, and I can really kind of intertwine my knowledge of pelvic with my general ortho population as well. So that's been really, really interesting. So kind of the goal of today is just introducing people to the pelvic floor and what the pelvic floor is and things we can do to kind of tune in and increase our awareness into the pelvic floor, because we do these really complex movements and we're lifting really heavy weights and we're doing all these things, but we don't realize that we need to be breathing appropriately. We don't realize that our pelvis is the foundation of our body. We can't do anything if we don't have a stable pelvis. So we go and we tell people to lift these loads and, push these weights around, and no one ever talks about the foundational component of what our body sits on, and that's our pelvis. So that's kind of what we're going to talk about today. I want you to just come away with just a basic foundation of kind of how the pelvic floor works, and like I said, exercises we can do to increase awareness, increase strength. I think one thing, kind of disclaimer, is, and we'll get more into this a little bit, is in order for me to really give you an individualized plan of like, you should do this, this, and this, I need to do an internal exam. So a lot of the things we're going to talk about today are things that are important for everyone. Everyone can do these things, whether you have a tight pelvic floor, a weak pelvic floor, prolapse, incontinence. These are things that everyone can and should be doing. But when it comes to an individualized specific plan, that's when you need an internal assessment so that I can assess how those muscles are moving. So just a disclaimer of like, this isn't gonna fix your incontinence, this isn't gonna fix your prolapse, all of those things, but this is gonna help you tune in and increase your awareness. And by that, you may see improvement in symptoms, but it's not going to fix those things. This is just a general overview of kind of what those things are and how the pelvis moves. So we'll kind of get into the first slide. What is the pelvic floor? So I have my handy dandy model. So this is pelvis. Your hip bones, so those hip bones you can feel in the front. If we look from the back, this is your sacrum. Down here is your coccyx. So that's the tailbone. When people are like, oh man, I hurt my tailbone. That's that bone down there. And we see there are muscles that attach on the coccyx. So when we look kind of from inside, so if I was like looking down on you, here are where we hold our pelvic organs. And this is a female pelvis. Disclaimer, men have pelvic floors, men have pelvises. A lot of people don't know that or realize that. Yeah. So when we kind of think about our pelvic floor, here are organs. So I can kind of take this out. So we have our bladder, uterus, and rectum. And I think one thing that's super interesting to note, kind of ovaries, is how anteriorly the bladder sits. It sits right on that pubic bone. So that is something that we'll kind of get into more, and then how deep kind of that rectal cavity sits. So as I take this out, nice thing we can remove organs. We're gonna look kind of from underneath. So when we think of the pelvic floor, we think of kind of its functions as the 5 S's. So just ignore half of my vertebrae falling off. So we have support. So this is gonna be the support. It holds up those organs in there. So the organs sit here, and this pelvic floor, these bowl of muscles, help support those pelvic organs. So your bladder, your uterus, rectum. We also have sphincteric. So it opens and it closes. So there's a lot of muscles here. So when we think of sphincters, these are sphincters. There are muscles surrounding them that close and open and are under voluntary and sometimes involuntary control. And so sphincteric is going to help open and close those muscles so that we can urinate, defecate, all of those fun things. And then obviously sexual, it's our sexual organs, arousal, all of those. Stability, this is the big one we're going to talk about today. Our pelvis is literally what our body sits on. Here's our pelvis. That's where your femur goes. So your femur attaches, this big leg bone, to the pelvis. Our body, our upper body, sits on the pelvis. So this is the primary way we search and seek and find stability in our body. Lastly, it's a sump pump. So it helps, these muscles are gonna squeeze and tighten to help move fluid, urine, fecal matter, semen, any of those things. When we think of the pelvic floor, kind of moving on to the next slide, we think of kind of 3 layers. So this is how we do our internal assessment, is we kind of like to look at all the different layers because they mean something to us. So we have this first outer layer, and obviously the skin is off. So we have this first layer, and it's more of a superficial layer. And this layer is what's gonna surround so we have rectum here, vagina, and then there'd be a small hole for urethra if I had the second part of this. And so this superficial layer is kind of what surrounds like external labia. It kind of goes right near like that bone, the sits bones we sit on, and it's very superficial. And so when I am treating someone and they say that they have pain with initial entry with intercourse, that's kind of the muscle I'm looking at. Or sometimes they'll have burning or chronic UTIs. Those are the muscles that I want to assess. Then we have the second layer, and this layer is really, really important, and it's more of a fascial layer. So fascia is like a deep connective tissue, and it's more of where a lot of our sphincters lie. So when people have trouble, like people have incontinence, whether it's fecal or whether urinary incontinence, I'm looking at how do those sphincters move? Can they close? Can they open? Are they opening on time? Are they mobile? Are they hypomobile? So I'm looking at all of those things, and that's where you're gonna get a lot of trigger points as well. And you can also tell it's really highly vascularized. So these are all nerves. So anybody, if you've ever heard of pudendal neuralgia, pudendal nerve is kind of the nerve that serves a lot of your sexual organs, and it can be really painful. That second layer is a lot of times where we can get some entrapment. And so we're really gonna look closely at that second layer. The third layer is this deep layer kind of in here. And this is gonna be the layer that does a lot of your like contracting and relaxing. This is the layer that a lot of times we focus a lot on because so many of us hold tension we don't even know we have in our pelvic floor. And these are the muscles that are kind of the culprit. And these are the muscles that really help hold and support those organs. So there's kind of three main ones we think of. They're big words. I'm gonna say them just for reference, but we have the levator ani, that's three different muscles. So you have your pubococcygeus. So basically that just goes from the coccyx, so the tailbone, up to the pubis. This is your pubic bone, that bone right in front that you can feel. Then we have the puborectalis, and this muscle is actually a muscle that slings around the rectum. So when I have someone that's kind of struggling with constipation or fecal incontinence, I'm really tuning into that puborectalis muscle. And then we have the iliococcygeus, and this is kind of the one that gets all the press, and a lot of times people have a lot of pain and tenderness because it's a really big muscle, and it is basically almost the entire floor of the pelvic floor, other than those two small slings. And then we have, lastly, in the pelvic floor, we have the coccygeus. So that is this muscle back here. So it goes from here to the coccyx. And that can cause a lot of, from here to the coccyx, that can cause a lot of tailbone pain. In pregnancy, when people say, I broke my tailbone, we can go in and actually it's easier for me to assess the coccyx internally. I can go in and there'll be times I will assess it and I can just go, whoop, and it doinks right back into place and then it'll slip out. Because if that muscle is tight and it attaches right here, it can just pull on that. So that's something that I really like to assess because the way our tailbone moves is also really important with stability and movement and pain. Then we have two more muscles, and these make more of like the posterior wall. So they're not considered pelvic floor muscles because they're not the floor, but they sit on the posterior wall. And these are so, so important. And I think this really helps put things together for people. So we first have the obturator internus. That muscle sits right in here, so right laterally. This is going to be your obturator foramen. So this is the obturator muscle. It comes out here and attaches on the hip. It moves the hip. It externally rotates the hip. So when you move your hip, you're moving your pelvic floor. That's why we focus so much on hip strengthening and hip opening, because as you lengthen these muscles, you are lengthening the pelvic floor. The next one, which can be a common cause of tons of pain, and a lot of even practitioners don't realize its connection, is the piriformis. A lot of people have heard of the piriformis or piriformis syndrome. That is that deep, deep ache you kind of get in your booty and it can shoot down your leg. A lot of times people that run a lot will get piriformis syndrome. You can people tell you to foam roll it, and it's just a really gnarly, just deep, just aggravating pain. And you see this big old nerve, that's your sciatic nerve. So in most of the population, the sciatic nerve, as my pelvis splits, the sciatic nerve runs underneath that piriformis. So if we have a really tight piriformis, you're going to clench right down on that sciatic nerve. In a few percentage of people, it actually runs through the piriformis. It goes straight through. And in fact, when I was in my cadaver lab in school, we had a cadaver that his sciatic nerve ran through the piriformis. So it was super interesting to see. And so a lot of times people are asymptomatic. They don't have any problems. But if you have a really tight inflamed piriformis, it's going to cause symptoms. And so many times we have practitioners that will just treat the piriformis, treat the glutes, treat the piriformis, and they're not getting relief. Most of the time they do. It's a pretty simple thing to fix, but if they're not getting relief, we need to look further. Where does this muscle come into? It comes in here through this foramen and attaches inside. It's the posterior wall of the pelvic floor. I can do an internal release of the piriformis. So we're treating externally. I'm treating over the glute. I'm dry needling. I'm rolling on it. I'm, rolling a lacrosse ball on it, and you're not seeing relief of symptoms. sometimes we'll get referrals and say, can you do an internal release? Because clearly we're not doing something correctly here. So let's see if we can get that other part of the muscle and release that. And you can only release it internally.
Thank you for taking my question. Thank you for taking
Yeah.
my question. What I'm curious about is I've had to go to the physical therapist because I keep on having a knee that rolls in, but I have pretty strong hips. Like, they keep on wanting me to strengthen my hips. My hips are strong, but for some reason the knee still sort of rolls in. Could that have something to do with the pelvic floor?
It certainly could have something to do with the pelvic floor. That's why internal assessments are so important. And it can also have something to do with kind of the way your femur is aligned, but definitely could have something to do with the pelvic floor, especially if you are experiencing any incontinence or if you feel like you just hold tension there. Those are muscles that we can look at because those are muscles that may be tight, may be weak, may be too long. So that's something that we love to look at. When we have people with hip pain and low back pain that are not responding to conventional therapy, that's when we get a lot of referrals. And I appreciate doing less invasive conventional therapy first because I don't think everyone needs to get, oh, you have low back pain, go to a pelvic floor therapist. I think we have tons of great orthopedic therapists that can treat you and get you better. But if you're not seeing full relief of symptoms, I think it's nice that people have another avenue. Before it was just like, well, you just have chronic back pain, go on with your life, and just gonna be. No, we have a second thing we can explore. Will it help your symptoms? Maybe, maybe not. But there's at least another avenue that we know clinically, anatomically is relevant to low back and your hip. So that's kind of an overview of what the pelvic floor is and some of the muscles. And men, reiterate this, have pelvic floors. Men have pelvic floor dysfunction as well. We see men, so kind of going on to the next slide, we will talk about, let's talk about what are some common problems that I see in my clinic. So we see urinary fecal incontinence. Disclaimer, incontinence. I think, I was telling Stephen this yesterday. I went round and round with a patient one time because I was like, you have incontinence. She's like, I don't have incontinence, I leak. That's incontinence. And we went round and round in a circle because there's such a stigma behind incontinence. People think, oh, I have incontinence, I lose full control of my bowel and bladder. That is very low percentage of the population. People that leak with coughing, sneezing, running, people that will void urine, stand up, they take 2 steps, then they leak a little more, that's incontinence. And so there's a huge spectrum of incontinence. You can have incontinence symptoms and actually not leak urine. So you can have urinary or, urgency incontinence and have the symptoms but not actually leak, which is that urgency is key in the hole. You're like, I gotta get to a bathroom now, or that urgency of, if I don't get to a bathroom now, I'm not gonna make it, but you always barely make it. Or you void, you stand up, oh, I think I have to go a little more, you sit back down. So you have symptoms of incontinence, you just don't have the leakage. So I think that's something that people don't love to admit, but it's normal, and it's just a fancy word for saying you leak a little bit. And I think something that most women think is normal is that, oh, I've had kids. Oh, I was a gymnast, or oh, I did all these impact activities, I should leak. Oh, when I laugh, when I sneeze, when I jump on the trampoline, I should leak. You should not leak. I don't care if you're 95 or 50 or 20. You should not leak urine. And if you do, there is something in your pelvic floor that's not functioning correctly. And so I really want to put that out there, is that it's common, it's not normal. It's common, it's not normal. You should not leak urine even if you are 95 years old. You shouldn't. Another thing we see is prolapse. That is when these organs...
Can I ask a question about the continence before you...
Yeah.
I think you kind of already answered it, but post-pregnancy, I had sort of, a lot of people are peeing themselves, but I had kind of the opposite problem. Like, everything was, super locked up. So, we'll probably get into that, but it confuses me on what I'm supposed to do, because when people talk about strengthening the pelvic floor, I'm like, mine might be too strong. But also, I mean, I think you basically just answered this, but I still now, like, I mean, I had a baby 7 years ago, but now recently, and I think it's like age related, I have the issue of like the needing to like I feel like I have to pee, but then like nothing comes out. So basically that's the same, that's also fits into the category of like maybe common, but not normal. Cause I hear more about, like I hear my friends talk about peeing themselves and I'm kind of like, I don't know where I fit in.
Yes, I love that. I love that. So just based on your symptoms, you probably have a very hypertonic kind of pelvic floor, high tone. And I'm gonna kind of get into that later, but to answer your question, a lot of times underneath high tone or tightness is weakness, but we cannot address the weakness until we address the tightness. So yes, we have kind of both ends of the spectrum. I'm treating a woman right now who had a baby at her 6-week checkup, got an IUD put in, and ever since she had that IUD put in, she's having similar urinary symptoms, fecal symptoms, as well as pain with intercourse. Because when she got that IUD put in, for some reason, just those muscles just tightened up, and so she's kind of having that similar problem. She's 6-7 weeks postpartum. So yes, there are both ends of the spectrum. And you can be tight and still leak. Okay. Yep. You can be tight and still leak. You can be weak and still leak. You can be strong and still leak because you don't have the right motor control. So you're strong, but you don't know how to fire and when to fire those muscles. So it's awareness. Same thing, you can be strong in your hips, but you don't know when to fire them. So you still have that collapsing.
Yeah, that's exactly right.
Right, so a lot of what we do is once we kind of assess internally, we look at, okay, are they tight? Are they weak? Are they strong? If they're strong, do they contract when they need to? And a lot of times the answer is no, because we're never taught, and you don't have a lot of awareness towards, towards the pelvis in general, so you don't think about those things. So kind of going back to other problems, prolapse. This is when those organs kind of drop down. So a lot of times people have just stage 1, stage 2 prolapse. So that is like internally, I can see, bladder has dropped a little bit, uterus or cervix has dropped a little bit, rectum has dropped a little bit. And there's really good evidence for stage 1 and stage 2 prolapse that pelvic floor physical therapy can help strengthen that and reduce those prolapse symptoms. So with prolapse, some of the things that people feel is they'll feel like they have pressure in their vagina, or they feel like something's falling out of their vagina. That's if someone says, I feel like something's falling out, it's like, thinking about prolapse. Then you have stage 3 and stage 4. Stage 3 is, it's coming all the way out to that vaginal opening. Like just resting position, I can see something kind of right at vaginal opening. Stage 4 is, it's all the way out. And with stage 4, a lot of times people have to self-splint to defecate or urinate. So they have to insert a thumb and splint it back up in order to pee or in order to poop. There are stage 3 and stage 4, there's not a great deal of evidence for PT because it is so lengthened. But we have seen patients that come in and have had reduction in their symptoms. In that case, we usually will refer you to urogyne. We work really closely with urology gynecology, and they can insert a pessary. And that pessary is just like a disc, and it just supports the bladder, supports the rectum. And a lot of times that can also get rid of some of your pelvic floor symptoms. And that a lot of times prolapse has a really strong correlation with low back pain. So a lot of times people with prolapse, especially grade 3, grade 4, we insert that pessary and it's like, oh my gosh, like my back symptoms are relieved. If you can imagine, it's just falling out kind of. So that's another common thing we see. We also just see pelvic pain. I have pain in my pelvis, or I have pain here. They can't really identify what it is. So chronic pelvic pain is just pain more than 6 months, more than, I think it's like 3 days a week, is kind of the definition of it. And that is, it's hard. We go back to it can be tight, it can be weak, it can be strong, but we don't know how to fire it. It can be spasmed, whole host of things. That's why internal exam is so important kind of in our field. Then we have vulvodynia, tomato. That's just pain around the external genitalia, like external labia. You just have pain. So like you go to wipe and you're like, man, this like hurts or burns. Or a lot of times when we see people with chronic UTIs, I'll be looking at that external layer, kind of seeing what is it doing as you're finishing peeing. Is it tightening up? And then are we, if you have a chronic UTI, is it tightening up? So then we're leaving a little bit of urine left in the urethra. Is that what's causing the UTI? I don't see that as much in my clinic. I see dyspareunia a ton, and it's my favorite thing to treat because it's so functional. And dyspareunia is a fancy word for pain with intercourse. Everyone here, sex should not be painful. Sex should be enjoyable. You should be able to climax. You should be able to have an orgasm. If you can't have an orgasm, there may be something wrong with your pelvic floor, because those are muscles that surround those organs, and surrounding your clitoris are muscles. Are those tight? Are those weak? We can assess all of those things. Do you have pain? We'll have people like, man, 30 minutes after, I'm like balled up in pain after I orgasm. Those muscles just don't know how to relax because it's this tensioning and then this relaxing. I could shout from the rooftops, sex shouldn't be painful. It should not be painful. And I see so many women in my clinic, and it's such a fun thing to treat because it's like you do a ton of relaxation, a ton of breathing, a ton of internal work, but I see such functional improvement of like, oh, we had sex this weekend and it was so much better. Or, oh, we had sex this weekend and we could do all these positions that we've never been able to do before. And it's just, I think I've seen it really help marriages. I've seen it because when you don't want to have intercourse because it's painful, like that's going to put a stress on your marriage. And so I see it a ton in my clinic and I love it. It's just a fun thing to treat because it's so functional. Vaginismus kind of goes along a little bit with the pain with intercourse, but vaginismus, we're just going to think of super, super spasmed muscles surrounding the vagina. So sometimes dyspareunia and vaginismus get a little blurred because you'll be like, man, I had pain with intercourse. So it's like dyspareunia, but then you go in, and when I think of vaginismus, so when I do an internal exam and I insert one digit, like that digit's hardly going in. And so they'll say like, I cannot use tampons. I can't, the thought of anything penetrating my vagina, it just sent like, no, I can't do it. So that's gonna be more vaginismus. Dyspareunia is you have, vulvar opening is pretty normal size, but it's just painful. Vaginismus is when it's literally tightened down and they're like, can't use tampons, can't have any sort of penetration. It's just doesn't work. So that's kind of where that goes. See that a lot in my clinic. I actually see that a lot in my younger population. So my 16-year-olds all the way up to low 20s, and usually come in, they're like, I can't use tampons, and that, or, I have pain or penetration, all of those things. So that's more common in my younger population, as well actually a little bit in my postmenopausal population, because as we age, we have general age-related changes in our pelvic floor. And so as you get to menopause and those estrogen levels are decreasing, you actually lose some bulk in that tissue. So that tissue starts to atrophy. So we kind of use it, so think of like my skin on my hand. It's good, it's mobile, it moves, it's a little thicker. And then think about, your grandma or your parents, hand, how it's kind of shriveled up a little bit. That's essentially what happens to some of the vaginal tissue, and you can struggle with vaginal dryness, and as that atrophies, sometimes you can get some shrinkage. So sometimes I will see vaginismus in my postmenopausal population, and for that, we do treat trigger point, we do treat internally, but we typically love to send you off to your OB-GYN or Urogyn and get a topical estrogen cream. It's pretty safe, pretty effective, but that topical estrogen just bulks up the tissue and makes it like a good beefy red color and nice and lubricated and all of those things that the tissue should be. And so those are just some aging changes. So a lot of times I'll have people come in and be like, man, it feels like sandpaper down there. And be like, okay, so it feels like sandpaper. Obviously I'll assess it. And some things I look for as a practitioner is the tissue should be red and beefy and like a good red color. If it's pale or has splotchiness or white, that kind of tells me your estrogen levels are probably decreasing or have decreased. And so it is not uncommon. Get a mirror, ladies, get a mirror, sit there. Look at your vagina. No one does that. Look at it. You can, I'm serious. Like, look at it. Inspect it. What does it look like? Every vagina is different. You can learn so much from just looking at it. It sounds crazy, but seriously.
What should we be looking for? Sorry. So like red color.
You should be looking for like beefy red color. Look for prolapse. Look for prolapse. Is there anything falling out of there? Look for where is perineum. So kind of oh, dang it, I don't have it. So the spot between kind of vagina and rectum, you have like a little layer of tissue. Like, where is that sitting? Is it super low? Like you can hardly see it? Or so a lot of times in, people that have not had children, it'll sit higher. So like when I am doing an internal exam, they can open their legs and I can see vagina really easily and almost even see rectum. People that have had lots of kids, it's like sunken down, and so I have to or even put their legs up on something because it's kind of farther underneath. All of those things, look at your contraction. So do a pelvic floor contraction. Do you see an ascent of the pelvic floor? Do a bulge. So like you're trying to let out, we always say like you're trying to poop or let out a fart or something. Do things drop out? Because if they do, they shouldn't. Cough. When you cough, do things drop down and open? Because when you cough, it should go whoop, because that's how you're doing a pelvic floor contraction when you cough. So that's what we do in our assessment. We'll lay back. We'll say, okay, go ahead and do a pelvic floor contraction. I have a digit inserted. I'm feeling for the strength, but I'm also looking to see, does it just go around or does it go around and move up? Does it close at all? There's women who have a 0. It just doesn't close. It doesn't do anything. Then I'll say, okay, bulge. You should see some movement. So if I had to take a very educated guess, for someone like you, when you say bulge, there's probably not a lot of movement. It probably just sits there because it's so tight. You can't move a tight tissue. It's just gonna sit there. So I do wanna see something move down. Now there's a line. Does it move down too much? And then we're looking at prolapsy type things. Or does it not move down at all? And that tells me, man, she has some really tight tissue that we need to loosen up. And then cough, okay? When I cough, do things just whoop, open up, or do things pull up? Then I'll have them, okay, perform a pelvic floor contraction or a Kegel. So you'll hear me use the word pelvic floor contraction, and it's the same thing as a Kegel. Okay, can you perform a Kegel and cough and maintain those things? A lot of times they can perform a Kegel as soon as they cough and increase in intra-abdominal pressure, they lose it. So look at those things in a mirror, see how it moves, what you can do, all of those things. Also it's good to look at your vagina at baseline. So if you have something that comes up, you can know yeah, no, this isn't normal. I need to go see someone, you're looking at your skin, look at your vagina, please. Okay. So kind of by the numbers, I think this is just kind of interesting. So 52% of female athletes experience incontinence. This is really how I got passionate about it, because I was an athlete and I was wanted to work with athletes and wanted to be an athletic population. I'm like, man, this is great. This just overlaps what I want to do, treating athletes, and then all these women have incontinence. And so it's been really fun. Ladies, you guys are athletes. I'm not talking about the 10, 15, 20-year-old, okay? That's what this stat is about, is, your college athletes, your high school athletes. But if you exercise regularly and you're moving your body, you're an athlete. Athletes don't have to be these crazy runners, these, crazy gymnasts or swimmers, or you do Pilates, you do yoga, you do any sort of exercise, you are an athlete. And I want you guys to get that in your head. You're an athlete. We're all athletes here, okay? So we can all, I think kind of just going, we just need to get that in our heads. We are athletes. it doesn't matter what you do or how you do it. If you're moving your body, you're one step ahead of most people. Secondly, 49%, and I think the stat probably is a little higher, of chronic low back pain patients have urinary incontinence. And I would probably beg to say the stat is a little bit higher. 43% of women and 31% of men have sexual dysfunction and pain with intercourse. We're talking almost half of the population, people. And let me tell you, you should be having sex till the day you die. See, so we have a few women in our clinic who are 80s and 90s, and they're coming to us for some pain with intercourse, and my boss and I talk like they are heroes. We want to be having sex until we can't have sex anymore, and you should. It shouldn't stop just because of aging changes, just because of tissue changes or pain. There are things we can do for that so that you aren't having pain. Lastly, I'm not going to go down a tangent. I told Stephen to stop me if I do. Kegels aren't always the best choice. And we're going to go down the tangent. Kegels, so I'm just going to read it. Kegels are the worst thing you can do for a tense, unrelaxing pelvic floor. That's why pelvic PT can determine if Kegels are appropriate. That's why we hate when you're incontinent? Oh, just do Kegels. Right. No, folks, no. Okay, so here's my bicep. Normal resting length is here. Probably like here. A Kegel, you want to get full here. If you're too lengthened, those fibers aren't going to be able to grab and you're not going to have any strength because it's too lengthened, and there's a lot of exercise physiology between like actin and myosin fibers. But if you're too lengthened, you can't grab anything to get the contraction. If you're just about right, you can get a really strong, good contraction. If you're here, you're already in a tight position. Why would you want to continue to tighten? So when someone says, oh, just go do Kegels. No, don't just go do Kegels. You need to be assessed because are you weak? Is that why you're incontinent? Or are you tight? Is that why if you're tight, we need to reduce that tightness and then strengthen. So go back. Underneath tightness, most times is weakness. The reason our bodies get tight and we're kind of moving into more of the strength stuff because we're seeking stability. So people that have low back pain, they are weak. So then those muscles in the back go whoop because they're weak and they're like, my body is seeking stability. My body is like searching for it. So the only way I can find stability is by guarding. So same with the pelvic floor. Your body is seeking stability. The only way you can get it, boom, tightening up. So that tightening is going to cause pain, incontinence, pain with intercourse, all of those things. So that's why it's really, really important to, if you're experiencing these symptoms, to get an internal assessment, because I can't tell you whether Kegels are the right thing to do. And then, are you contracting, are you doing a Kegel correctly? So that is hard to tell. I can tell a little bit externally, but that's really hard to tell unless I am internal, inserted vaginally, and I can feel what are those tissues doing. Are they going all the way around? So that's about, if they go all the way around and squeeze my finger, that's probably a 3 out of 5 contraction. If they go all the way around and pull up a little bit, that's probably a 4. If they go all the way around and pull up, that's a 5. I've had a patient that had dyspareunia, pain with intercourse, came in, tested her contraction. She popped my knuckle. Oh, yeah, because she was so tight. So once we got her loosened up, there was weakness underneath that, but she was so tight. She did her pelvic floor and she popped my knuckle. So, and then obviously she wasn't having any of the leakage stuff, but so many times it's just just do Kegels. Just do Kegels. No, I need to assess what that's like. So then we have a grade 2, which is a lot of times we'll just get an anterior or posterior lift, just like one of them goes up or one of them goes up. And then kind of between a 0 and a 1 is just a little. And then I've had people that have had a grade 0, but aren't coming to me for leakage. So their pelvic floor is contracting at some point, otherwise they would have no continence. But when you ask them, they cannot motor plan it. They cannot, in their heads, motor plan how to squeeze those muscles. They have such little awareness that they don't know what a lot of times they'll be squeezing their abs or squeezing their booty, kind of all those things. When I see, so I'll have them do that, and then I love to see, can we engage those deep core stabilizing? So the big muscle, and I'm gonna say TA a lot, that means your transverse abdominis. That's your deepest of your deep core muscles. Can we contract our TA and just isolate that? With a TA contraction, you get a pelvic floor contraction because of where the TA attaches to. So sometimes I'll be like, okay, let's just go away from your pelvic floor because you can't, we're not even there. And then I'll like, okay, TA, and even, I don't love to do this, but I'll even have them co-contract glutes. Because a lot of times with glutes, you can feel yourself kind of squeeze up. So I want to get away from that ultimately, but when they can't do it at all, I'm bringing in all the muscles to try and get some form of a lift. So kind of moving through that, we're going to talk just basically about the foundational concepts of strength training. So we've kind of gone into it, but mobility versus stability. We need a very we need a good balance of mobility and stability. And that's really hard. A lot of us, I would say generally, most people are hypomobile. We don't have a lot of mobility, especially in our hips. They're tight. We are a very sedentary population. We sit a lot. In the way we sit, we don't sit in very ergonomic positions. So we have tight hips, tight musculature. So our body, also stability, you get that stability from your deep kind of lumbopelvic stabilizers. So we're fancy multifidus and quadratus lumborum. A lot of times when people have tightness in their low back, I'm looking at what we call it the QL, the quadratus lumborum. That's the one that really goes, like, because they're just trying to create stability somewhere. That's a big muscle that commonly is like the culprit of a lot of low back pain. But we need those to work together. If your back is too strong and your core is not strong enough, you're gonna do some weird stuff with your pelvis. Opposite way, if your core is too strong and your back's not strong enough, you're gonna be doing weird stuff with your pelvis as well. So this fine line between being mobile but being stable. And that's kind of what our big focus on, that's what so much of PT school is about when we assess movement, is looking, any joint I look at, I'm looking at mobility and stability. That's the foundational concept of physical therapy. If they're not mobile, we need to move it. If they're not stable, we need to strengthen it. But we need to do it in a manner that's in we need to find mobility first, because otherwise we're strengthening a super small range. So we need to find mobility, and then we need to strengthen that range. Second, length tension relationship. So this kind of goes along with the mobility and stability thing. But like I was saying, so you want to have the appropriate length of a muscle, because that's going to create the appropriate tension in the muscle. So if you're too short, you're going to have too much tension, and you're going to create spasm and pain and dysfunction. If you're too long, you're not going to be able to create any force because your muscle is so lengthened out. So it's kind of finding that balance of length tension, and that's a lot about what kind of our coursework is about too, is how can we put people in, ideal positions to help them achieve that proper length tension relationship. Then kind of performing movements in different planes is key. So I think one of the reasons I really wanted to come here today is because I really appreciate how Steven trains his clients, because he has knowledge of that. We don't move in what we call the sagittal plane. We don't move in this direction all day. We have to turn, we have to squat, we have to pivot, we have to rotate. So when we think about planes of movement, we have sagittal plane, which is kind of this direction, frontal plane, which is this direction, and then transverse plane, which is more of like a swivel. Functional movements usually are a combination of all three planes. So we have knowledge to start you in a plane that's going to be the easiest to kind of feel and contract. So we'll start in a single plane, and a lot of times that's lying on your back, kind of without gravity kind of bearing down as much on you. But then we want to move functionally into more planes. So can I cue those contractions or the right muscles when I'm doing functional planes in more than just one movement. Because then once you do something that's outside of that one movement, those muscles will be like, what? I need to work? What? I've only ever been trained in this plane. So it's so important to do things in different planes. And we'll get into, I have tons of examples of like what that looks like from a strength training standpoint. And then make it functional. I think we get so bogged down in therapy of like just having them on their side and doing, clamshells, which is a great exercise. I love clamshells for strengthening hips. But is that functional? That's not super functional. Let's do something where they're standing and moving and doing something that they would be doing and, standing on one leg as I'm doing right now. Let's make it functional so that it can be transferable. If it's not functional, it's going to be hard to transfer into kind of your everyday life. So, moving forward, pressure system and load transfer. We've kind of gotten into this, but we have this pressure in our body. It has to be managed and dispersed. You can't just, otherwise it'd just be sitting on your pelvic floor. And so you have this pressure, you have these loads. When you walk, you have a load, a ground force reaction that needs to be dispersed into all different parts of your muscle. All the way up here, because if we're walking and we don't have loads dispersed up here, we're just gonna collapse over. Load transfer is the ability to manage those forces. So I go from double leg to single leg, how well can I transfer those forces appropriately and correctly? Our pelvic girdle, pelvic girdle, hip bones, so when we think of pelvic girdle, we think of kind of deep lumbopelvic stabilizers, deep core stabilizers, hip bones, pelvic floor, and glutes. Pelvic girdle is the support system of all of our abdomen and our organs. We need to strengthen all of those things to find stability, but we need to strengthen them in a way that's functional. So again, so many times I think we don't strengthen in a functional way, and so we don't have a lot of carryover into just everyday life. And that's something that I'm continuously learning is how do we make it functional? What does functional look like? And so that's kind of just a pressure system and load. Those are just some basic concepts that seem pretty black and white. Like you have a load, you have to transfer it. People could talk 4 hours about this. All right, moving on. Breathing. It's really, really, really important. Clearly, obviously, to keep us alive. It's a vital function, right? But if you come away with nothing from this talk other than breathing, I think I've done a good job. Because it's so important and it can change so much about how we move. So, our pelvic floor works in tandem with our respiratory system, specifically our diaphragm. If you move to the next page, I have breath mechanics slide. So resting, our diaphragm is a domed shape thing. It's just resting. When I inhale, that now drops down. When that drops down, it pushes force into the abdomen, which pushes force down into the pelvic floor. Now we are lengthening. This is where we start to increase our awareness of our pelvic floor because you want a good length tension ratio of our pelvic floor. So we are going to get into some breath mechanics here in a minute. I'm going to kind of finish through these. So we have this intra-abdominal pressure. So when we go hold our breath, that increases our intra-abdominal pressure. That is really important. Managing that is probably the most vital thing to pelvic floor health, is how well we manage that intra-abdominal pressure. Because if we are tense, if we're in a state of tension and breath holding, it's gonna be it's this weird lengthened but also tightened, this weird relationship in our pelvic floor. So like I said, with inhalation, the diaphragm drops down, lengthens the pelvic floor. This is one way we can get pelvic floor lengthening and stretching just by breathing. You don't have to do any movements, you're just breathing. To add that, we can breathe in different positions, and we'll get into that. So I love to breathe. This is another kind of like a yogi squat. This is another position where now we are in a very lengthened pelvic floor. So we've already lengthened some. You naturally have to lengthen to get in this position. I will tell people, how long do I hold this? Hold it for 20 breaths. And I like this position because A, it's a hip opener, B, you can feel it, but C, if I'm breathing correctly, I can feel my abdomen expand into my thighs. So that is something that you can focus on. So now we're getting a ton of lengthening, and you just kind of relax and just see. And sometimes you'll get, I'll tell people, like, it almost feels like if you have a full bladder, it feels like you might like pee a little bit if you're that lengthened and that relaxed, especially because that bladder sits so close here. You can kind of feel a little pressure. There are other positions that I love people to breathe in, and we'll kind of go over those. So, one more thing. There's a correlation with altered breath mechanics and low back and pelvic pain. This was a huge study done by Smith in 2007, so it's been a while, but it was, there was a really, really strong correlation between those things of people that have low back pain just by looking at their breath mechanics. No therapy, no conventional PT, just looking at those breath mechanics improved low back and pelvic pain. Some of it could be just general relaxation. Some of it is that awareness, and some of it truly is we are getting muscular change in the length and the tension.
When you talk about breath mechanics, can you expand on that a little bit?
Yep, we're getting into that right now. Yep. Okay. So, everyone in sitting, have you guys heard the term belly breathing before? Yep. So I love that term, but I also kind of don't at the same time, because I think there's just been this notion that when you breathe, or correct diaphragmatic breath or belly breathing is just your belly expanding. No, it's 1/3, your chest should move. If you're breathing correctly, your chest should move a little bit. Your ribs, so about 1/3 chest, 1/3 ribs, and 1/3 abdomen. A lot of people, I will have them lying down on their backs, and they physically cannot cue that. It's that. So they're getting no lengthening of their pelvic floor. I mean, they're getting some, but it's all coming through their chest. So they're lifting up to breathe instead of to breathe. So you want your abdomen to expand. You also, this is so important, I want everyone to feel their ribs. Put your hands on your ribs. Can you pull your ribs down and in? If you can, that tells me they're probably just sitting a little high, which is super common. So they're already sitting a little bit flared. So I will get people that will come in, and I will be able to, actually, can you come up and lie on your back for me?
Doesn't matter which direction.
No. So I will come here, and I will come into their ribs, and I will just pull them down and in. And that's where your ribs should sit. But we have so much tension, and especially if you've had babies. Because a lot of times, you know, you'll see like babies sit high or sit low, but regardless, they have to go somewhere, so they're gonna go out. So when I get moms postpartum, one of my favorite things to do is I'll grab their ribs and pull them in, and they just like sink into you, like, oh my gosh, this feels so good. Because it's like this stretch of like, whoa, like this is where it's just like, oh, it feels so good. So you can just pull your ribs down and in, and you're mobilizing your ribs. You're mobilizing your ribs. So I will just come here, and I will go. That feel different?
Yeah, yeah.
So that's where your ribs should sit. But a lot of times we're super tight in our lats. We have super tight in our pecs. We sit like this all day. So all these are super tight, and they just pull our ribs. They pull our ribs out, and they flare our ribs. So if we have rib dysfunction, you're not gonna have the right breath mechanics. So that's something I love to look at, is how do your ribs move? Like, can I move them? And if I can, I love to just come in and just just mobilize them a little bit. And you can do that on yourself. You can take a TheraBand or a towel. This one might be a little tight. Let's see if I have a longer one. And just, this one's not gonna get it, so a towel would be better, but you can just pull them down and pull them down and pull them down. And then you can come here. So I have a little resistance. Resistance can be really good for awareness, and I can practice my breath. Am I feeling this expand? And it should expand out, not up. If it's expanding vertically, then we know we're using more chest. So I love to start just in this position. I'll just have one hand on my belly, one hand on my chest, or one hand on my ribs, and I'll just go. And I don't get a lot of rib movement. That's one thing I know. My ribs don't move super well. And so I do have pretty good abdomen movement, but if I don't have rib movement, I'm gonna get it from somewhere else, and I'm likely getting it from my chest. And I will have people just do 10 to 20 breaths in this posture. And as you breathe out, just continue to feel like that pelvic floor is lengthening, lengthening, lengthening. So that's a great position. Another great position is this yogi pose position. I love it because you're getting hip opening. Again, you're kind of providing resistance on your tummy. You can feel your ribs. And I actually do a better job in this position of getting some rib expansion, than I do in the supine position. So that's something you'll also notice. There are certain positions you'll get better movement, and I couldn't tell you why. It could be the force of gravity. It could just be how your muscles, the length tension of my muscles, my shoulders, things like that. So try different positions. We love, love, love a quadruped position, or all fours. Come here, just
You're wanting that same lengthening, like outward.
Yep.
All that, okay.
Yep, we love that. Then we can move to sitting, we can move to standing. We can move to one leg, functional. Oh, that's hard, you know. And you'll find I'm a chest breather when I'm in single leg stance because my abs are like really turned on. So I'm having a hard time letting my abdomen go, but still maintaining that abdominal contraction. But those are things you can focus on. You can try 10 to 20 breaths. It doesn't take, you can be doing the dishes. And I'm telling you, just breathing and tuning in to your pelvic floor, it's like night and day. You're like, whoa, it exists. It's a thing. And you'll be in your everyday life and you'll be like, man, like I'm really I'm really holding my pelvic floor right now. You know, like, oh, let me do a few like good belly breaths. So when I say belly breaths, your chest should still move a little bit. But if you're getting all your movement from your chest, yeah, we really got to focus. And then pull those ribs down and in. Pull them in. Pull them in. It's like, it's just like relief because we're so tight all through these muscles because we all have such poor posture that it feels so good to just pull them down and in. It's like, oh man, that's where my ribs should be sitting.
Yeah, it was very relaxing when you did it to me, yeah.
Yeah, you're like, oh my gosh, like my ribs should be sitting there. And it feels like this stretch and it's amazing.
I have a quick question.
Yeah.
Like when you're breathing, what should we be noticing that we're activating our pelvic floor?
When you're breathing, I don't want you to activate anything. When you're breathing, you're focusing on abdomen and ribs, because you are then secondarily getting a lengthening of the pelvic floor. When you breathe out, I want you to continue that lengthening. So a lot of times when we breathe out, we'll go, so I just want you to like lengthen, 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 lengthen. That's what so as I'll say abdomen, ribs, and then as I breathe out, pelvic floor, lengthen, 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 lengthen. So you can just maintain this lengthened position. So it's more focused on the ribs and the abs.
So I've heard people say when they ask you to practice breathing, they say ribs down breathing. So is that what they're talking about? Because I get kind of confused.
Yes. So when they say ribs down, I think because when people breathe, they will flare and they'll flare up, and that's incorrect. You want them to flare out. So your ribs are down, but they're moving out, not up. So if they're immobile. Yeah. No. If they're moving this way, like flaring, that's incorrect breath mechanics. So, and if you notice that, give your ribs a little hug. Like, give them a little hug and work on just the rib movement. You don't have to do all three at once. Just work on belly breathing at first. Can I get my belly to expand and relax? Break it down. Okay, now I have the belly. Let's move up to the ribs. I'm gonna forget about everything else. Can I just get my ribs to expand horizontally and come in? Can I, keep my chest nice and quiet, and then put those three things together. They don't have to go together immediately.
Okay, I might be being dense, but I don't necessarily get when you breathe out, lengthening, breathe in, lengthen. Like, I get the concept behind it, but does that mean psychologically we're thinking about lengthening and we don't feel it, or does that mean we are supposed to be feeling something?
No, you shouldn't feel a whole lot, but I think there's a really powerful brain-body connection. So when we're visualizing, what does lengthening look like, it, getting longer, when we're telling ourselves and visualizing it, I think it can help keep that pelvic floor relaxed. You shouldn't feel tissue stretching, that you're not gonna feel that. But I think there's a lot of power behind telling your brain something and your body doing it. And so it's more of okay, I'm telling my pelvic floor to lengthen. I'm not feeling anything. If I tell it to, we're hoping that it'll just relax down. Does that kind of answer your question?
That does.
Okay, yeah. All right, so moving on from breathing, we did breath mechanics. We've already talked about pelvic girdle stability. You have in the deep core, we have that transverse abdominis. That's the deepest muscle. And this is gonna be our anterior stability. So a lot of times when people have anterior instability, and I can feel that on an internal exam, I'm looking at transverse abdominis and your obliques. Our rectus abdominis, that one muscle that gives you really nice, cute six-pack abs that I certainly don't have. It's nice and it's pretty, and society says it's the be-all, end-all, but it's not functional. It's not a functional muscle. It doesn't do a whole lot. There are people that have tons of that. I'll get them, they have six packs and they still have incontinence. They still have leakage because they're deep. And if anything, it's a problem because it's so tight, it takes over. So then the obliques and the TA are just like, I don't have to work. The abs are gonna do everything. My rectus is gonna do everything. So then they just shut off even more because it's like, no, I'm not gonna, nah. Our bodies take the path of least resistance. Whatever's the easiest, it's gonna do. And so that's why mindfulness and awareness is so valuable, because if we just resort to kind of what things just naturally do, it's just gonna be the path of least resistance. So it serves a purpose. Yes, your rectus provides you stability. It does. It's a muscle attaches to your pelvis, but in the grand scheme of things, it doesn't do a whole lot. Where you're gonna get that true stability and, kind of true change is in those deep core, so your obliques and your transverse abdominis. Then posteriorly, this is also part of kind of pelvic girdle. We have that quadratus lumborum. It's like a deep kind of lumbar stabilizer, and then multifidus, which attaches right on the spine. So those are common muscles that are super, super tight, and then ultimately super, super weak, because that's where we get people with low back pain, women who have more of an anterior pelvic tilt. Those muscles are just gonna grab on because it's seeking some form of pelvic stability. That's why a lot of people have that pain, is because the QL and the multifidi are just grabbing on. So we want to reduce the tension, and then strengthen so that they have a good length tension ratio of they're the right length and the right tension, and now we're functioning at an optimal state and we don't have pain. And then we have our glutes. So glute med, glute min, our glute max is functional, and our hip external rotators, like we talked about, piriformis, quadratus lumborum, those all attach in the pelvic floor. So we can utilize that to help increase strength. There's a really, really cool study that basically took women, or I guess nursing home residents that were pretty incontinent, and they just had them do just supine, just moving their hips apart with a band like this, like 50 reps a day, nothing else. And most of them were bed bound, improved continence by like 50%. Just strengthening hip external rotators, because we know that that helps, strengthen the pelvic floor. And I think too, with women, we have wider set pelvises, which is good because we're, made for childbearing. And so with the wider set pelvis, we're more prone to glute and hip weakness because the angle which they attach to our femur and attach to our back, they're at a little bit of a steeper angle. So that puts that length tension relationship. They're a little bit more lengthened than they should be, so then they get a little bit weaker. So there's actually like some anatomical positioning that causes weaker hips and weaker glutes just because we're females, and it's just kind of the unfortunate event. Okay, last thing, we're gonna get into the fun stuff. Functional movements. What does this look like? So no matter what you do, Pilates, yoga, walking, there's things that we can do functionally. So I'm going to just show you some of my favorite exercises to do. And you can do these body weights. You can do them with weights. We'll start with kind of the first one, a single arm row. So a lot of times you see a single arm row and it's just boom. Yes, we're strengthening up here. That's great. How can we make that functional? How can we add in pelvic floor and TA and core stabilize? Let's get in this quadruped position. Okay, if this is where we're starting at, if you don't feel super stable here, then this is your starting point. By just me doing this, now that I only have 3 limbs on the ground and I have this force that if I wasn't stabilizing over my left, that I'd just like fall over, I can feel things tightening up and gravity wants to pull me down, and so I'm pulling it up. So for a lot of my patients, this is where I'll start. I'll just start here and they can feel contraction. As we increase, okay, now we go to one leg. Here. We can even try same leg, which I can't do. But you can find other things to make it functional, a normal row. How do we make that functional? Same thing. Okay, we have, you do push press, or you're just pressing up, strengthening shoulders. We can, okay, come on our back. Now let's go in this position. Now we're in an unstable position and we're having to activate core so that we don't bridge up. So now I'm pressing, I'm getting the same thing here.
And you're thinking about your rib cage, making sure it's
down. Yep, because I can feel my ribs want to flare, but you can, pull them out. And attaching the breath with the movement. So they say kind of exhale on exertion, because now we're lengthening and we're not tightening, and so you're not getting the pelvic floor is at a unlengthened state and then you're tightening it some more. We want to lengthen it and contract in that lengthened state. So, Okay, so now I'm again in an unstable surface. We can go into a bridge. So now I have to activate my core, and we can do that here. Same thing, changing it up. So now that same arm, same leg are unstable, I'm having to use a little bit more core. So you're doing that same thing, but making it functional. We're doing it in multiple planes. And let me tell you, you don't have to be strong to do these movements. Use 3 pounds, use 4 pounds. Do your body weight, get a resistance band, put it under your butt. Okay? You don't have to be lifting heavy weights to do these positions. Do what you can. You can scale it back, scale it forward. It gets easier, you make it a little bit harder. How do we make things harder? Generally, we take a level of stability away from us. That is taking something off the ground to create a more unstable surface. So then we'll go to like a half lunge, kind of Pallof press. Oops. So I love this position. I love a lunge position. We're working in a sagittal plane. This is really functional. So in order for me to be in this position, I've narrowed my stance. So now core has to be engaged or I'm just gonna plop over. And now I'm adding a rotational component. This is super functional. Moms with kids, picking up a car seat, putting it into, picking up your groceries, putting them on, the counter, whatever you're doing, this is really functional. So we can do that. Okay, that's too easy. Okay, come up into a lunge. Now I have glutes, core, all of those things. Okay, that's too easy. Put my back leg on an unstable surface. So there's so many things that you can do, basic things. You don't need a gym. You can do these in your house. You can have resistance bands, all of those things. So that's kind of a half lunge Pallof press. These exercises I'm showing you are the ones that I do constantly with these are pretty much the ones that I go after because for all levels. I can do it for my mom that's postpartum at 4 weeks and still just feels like everything's kind of falling out of her. And I can do this, I can do this for my 85-year-old patient. You can do it for anyone. You can modify, they have low back pain. Okay, we can put something under their knees or there's tons of modifications. Then we'll do plank with hip abduction. So a lot of times people go, oh man, when I do jumping jacks, I pee myself. Okay, then let's get in another position and try a jumping jack. So let's go into a plank and do a plank jack. And yes, that's really, really challenging on your shoulders. But if you can't do that full, okay, one at a time. If that's even hard, we can come here and we can just move out. So this is a little bit different exercise, but now we're on hands and knees. Or you can have a band and you can tap out. Tap out. Okay, that's hard. Tap out. Okay. Start with the most stable thing. So start with full contact with the ground. So typically all 4 limbs, body parts on the ground. And remove one as you see fit. A lot of the things I do, I make them up. We talk about, we make them up. And if it works, if it feels good, then we keep doing it. If you're like, oh, I don't really feel much, do something else. There's really not a huge method to our madness. We talk about that a lot in our clinic. We're like, no, well, it works. We find all sorts of new and innovative exercises oh, I've never seen that before. Where'd you come up, or where'd you find that? I just came up with it, It's really, it's people think we have all this innovative knowledge and we really don't. We just have this basic foundational knowledge of movement and we use that to come up with exercises. Another one. So people have a really, really hard time activating their transverse abdominis because rectus wants to take over. So we're gonna spend the last few minutes, I've gone a little bit over, we're gonna spend the last few minutes kind of how I have found that awareness can be found the best for that TA. So I love to start in a lengthened position. So that's gonna be supine or on your back all the way down. And I'm gonna move over here and I I'm gonna hold on to something. So the reason I think, and again, there's actually no physiological evidence to this. This is just something me and a few people in my clinic have found, is we feel like by stretching here, we're now stretching that rectus abdominis. So we're pulling it too far. So now it can't work. So we're basically using that to our advantage, that length tension relationship. Like, okay, I pull that rectus really far. Now it's at a disadvantage. So now I can come here and I will even start, you will feel so your hip bones, and right underneath your hip bones, you'll feel like this stretch almost because you're stretching that TA. And I will just work on pulling belly button to spine and pulling belly button to spine as I'm really, I'm pulling this to really take away that rectus. And I can feel it really firing. Add your breath in. As you exhale, you can feel it. Exhale with the effort. As I exhale, I really feel that pull. And it's gonna be those hip bones you feel right underneath there. You're gonna feel that. So then I'm cueing that, and then I will add a weight. So I'll be here. And now, because as I go back, farther back, I'm tensioning or lengthening that rectus, putting it at a disadvantage. The only way I can stabilize myself without literally popping up is by using those deep stabilizers. And then the progression would be going on a decline. So you put one of those benches down and you're going this way, and then you go over your head. Yep, and that's one of my favorite exercises to do. Is an overhead press. So that's kind of how you can look at strengthening the TA. One more thing. I love single leg stance, as you could tell. I loved kind of this. I loved getting into a one leg. Anytime you get onto one leg, in order to get stability, you have to activate those lumbopelvic stabilizers. So another basic exercise is a single leg RDL. I'll have them on one leg, kind of come back here. Okay. Ooh. And now I'll do hip abduction. There is actually evidence, anatomical evidence, by using your upper extremities in these exercises. You notice almost every single one of these upper extremities were involved. The way your upper extremity works is your lat and your serratus anterior, which are shoulder muscles. They have fascial connections, so fascia, to your obliques, which have fascial connections to your TA. So when I have people that cannot isolate their abs, I will just start with upper extremity movement because they don't know it, but they're using their core. So anything we do, okay, now we're stable. Okay, I obviously have to activate my core to be in this, or otherwise I'd fall over. But now we really want to get to those deep stabilizers. By activating upper extremity, we can activate those deep stabilizers. Same thing here. We'll go here. Boom. Squeeze your scaps together. Great for postural things. Okay. I'm getting single leg stability. I'm not dropping here, so my glutes have to be engaged. My glutes are on fire right now. Core is on fire. Okay, that's too easy. I won't be able to do this, but yeah. I've tried this in the clinic with patients. I'm like, yeah, okay. So here, there, So you just put yourself on an unstable surface. You just keep removing those barriers, okay? It's easy on a stable surface. Let's go there. As you get better, you could incorporate some jumping, okay? A lot of people have leakage and stuff with jumping. That could look like something like that. That could look like that because now we're getting all of that together. You could slowly incorporate, okay, things like that. You can start incorporating the things that you have your symptoms with as you get stronger. So that's kind of what progression looks like. And again, you guys are all athletes. You guys are capable of doing every single one of these exercises, just in a modified version. My 90-year-old patient is capable of getting on her back on a table and doing every single one of these. Maybe she does a double leg bridge, and maybe I give her just arms to go straight overhead. Okay, I have my 20-year-old athlete. Okay, I'm gonna challenge. Okay, you're on a BOSU going backwards. My 30-year-old bodybuilder that has 12-pack abs. Oh, I'm like, oh, we're gonna do body weight. And they're like, body weight. And then after 10 reps, they're like, oh my gosh, you know, because I'm making them use these stabilizers that they don't use because they're so strong. So then those other muscles just stop working, hence why they have dysfunction and they're coming to see me. So I hope that was helpful. Any questions? Feel free to come up to me after too if it's something personal or you just want to, yeah. One second, just so they can pick it up on the camera.
Do you, to go and see you for like an internal where you get the full, do you, is it covered by insurance? Like, do you need your primary to put the order in?
Yeah, so I'm a physical therapist. I work at Mizzou Therapy Services. I work actually over at the Battle location, but we have, within our system, we have 6 pelvic therapists. I'm actually the least experienced one. I'm pretty new out of grad school. I've done the coursework, but they're all fantastic. So I'm one of the least experienced ones, so you're gonna get amazing care. We really have a really strong pelvic health kind of program. But yes, it's covered by insurance. It's physical therapy. Sex is functional, peeing is functional. It was a big fight for a long time saying sex is a functional activity, but it is, folks. So yes, a lot of times you just can, if you have the portal or whatever, you can just email your primary and be like, I would really love a referral to pelvic floor therapy. And most of the time, they don't even need to see you. A lot of them know us, a lot of them trust us, thankfully, and we're not ever really gonna do harm. So most of the time, you don't even have to go and do the copay and get a doctor's visit. If you have one coming up with your OB-GYN or your primary, you can just ask them and they will write a referral. We're pretty popular people, so it's like about 6 weeks to get into us right now. But you can always start with these. And then I have business cards. Y'all feel free to email me. I love emailing. I'm super passionate about this. So I'm happy to, email you back and get you started with something until you can get in. And the whole point was, a lot of you guys, if you don't have a lot of dysfunction, you don't need to come for an internal exam. If you do and it's something you want, we're more than happy to. But I think knowledge is power, and just having knowledge about what these things are and increasing your awareness can also just be a really powerful tool to help us. And when you're with your girlfriends and they're like, haha, I pee my pants, you can be like, that's not normal, Like, ha ha ha, like, man, sex hurts so bad, like, I just need to drink a glass of wine, ha ha ha, no, that's not normal, All of those things, knowledge is power, and so I'm just super passionate about all of these things. So thank you all so much for coming. I do have business cards, just for my contact information more than anything, but we have South Providence has a pelvic therapist, Rangeline has a pelvic therapist, or 2, Battle has pelvic therapists, MOI has a pelvic therapist, and I think that's it. Forum used to, but she just left to go start the pelvic therapy over at Boone. So also, if insurance is via Boone, Beth, God, I forget her last name, she just started that program over there, so she's fantastic. Anybody has stuff at the VA, Sammy Turley just left us to go to the VA. So we're sad to see them, but we're also really happy that we are getting more providers and more access to patients and clients. So, but yes, insurance covers it almost always, just your copay and deductible and all those things, but yep, it should be covered.